TACT is really such a unique clinical trial. It's unique in many ways, but primarily because it gave us information we did not expect. For a scientist, that seems to be an odd thing to say, but in fact, very often we do studies and we think we know what we're going to find, and in fact, that's what we find. This is an extraordinary event where we, the conventional cardiology community, expected a negative trial, and instead, we got a new handle on treatment for patients who are the most vulnerable to heart disease. So who should learn about this? Well, it's hard for me to imagine who should not. Physicians who take care of patients with coronary disease should know about this. Patients with coronary disease should know about this. Individuals who have the likelihood of either treating or being themselves exposed to toxic metals should know about this. I think that this really needs to be learned by the medical community as part of the standardized curriculum. The time when we can ignore that toxic metals are harming our patient populations is past. It passed the day that we unblinded TACT. During that lecture, what we are going to be hearing is some of the newer results from our previous study, TACT, the Trial to Assess Chelation Therapy. As you recall, TACT was originally designed as a safety and efficacy study of disodium EDTA chelation therapy, delivered in a standard way, along with vitamin C, some B vitamins, some local anesthetic, and a couple of other components in the infusion, with a target of 40 infusions per patient, and accompanied by large doses of oral multivitamins and multiminerals that were antioxidants. Now, I'm a conventional cardiologist, and as a conventional cardiologist, I was literally shocked at the results of TACT. So why should that be shocking, and what are the implications? And that's really what I want to spend a lot of time on this lecture. And the implications really are that environmental pollutants are modifiable risk factors for atherosclerotic disease. These metals, primarily lead and cadmium, are vasculotoxic, and they poison the arteries. They do so more in our most vulnerable patients, who are the diabetics, and consequently, increasing the excretion of those metals with disodium EDTA appears to have a tremendously beneficial effect. Now, when I say tremendously beneficial, I'm not exaggerating. The numbers that we obtained in TACT are beyond what you would expect from any of our conventional treatments. We're at a watershed moment in which the treatment that has been developed by the alternative medicine community will be implemented by the conventional cardiology community. We need one more step in order to make that be true. And that step is one that by the time that you hear this lecture, we will know how near or how far away it is. And that is a replicative study called TACT-2. Remember that the hallmark of science is to be able to reproduce your results. So I went to the FDA with a team from Duke and with NIH scientists and presented the results of TACT. The FDA was very receptive, but they said, you need to reproduce this. In fact, the hallmark of science is to be able to reproduce your results. And so we've designed a trial named TACT-2, which right now exists as an application. That application will be reviewed on July 8th, which is a little over a month from the time that I'm recording this video. So by the time that this video is seen by most of you, we will know if we have a fundable score or if we have to go back, revise, and resubmit. TACT 2 will be a randomized clinical trial in which patients will receive either the standard EDTA infusion that we used in TACT 1 plus oral multivitamins and multiminerals versus placebo, in addition to conventional care for post-MI patients. But all patients will have diabetes. That is where we saw the highest and best signal of benefit, and in fact, a very low signal of harm, no signal of harm, in fact. So, as I said a little while ago, we are at a watershed moment. We think we've identified these metals that are particularly vasculotoxic, that upon increasing their excretion, patients do better, and we need one more study to get to the finish line. We are still recruiting sites, and so I will be at the ACAM meeting, and if you think that you have what it takes, as they say for the Marines, to be a study site, please approach me, and we'll talk about it. I look forward to meeting all of you, and I hope that we have a good discussion and a good debate. I always learn something at ACAM meetings.